Okay, good afternoon, everyone, and welcome to our Module 2 Shared Governance meeting. I'm John. I am the nursing director here, and I am honored to lead today's interdisciplinary evidence-based practice committee to address a pressing issue. Okay, so our hospital has been on capacity alert for over a week now due to overcrowding and delayed patient flow. We are experiencing significant delays in admission, discharges, and transfers. And this is leading to medication errors, workflow inefficiencies, and nurse burnout. Our goal today is to design a structured EBP-driven action plan using turnover teams, technology, discharge lounges, and predictive tools that will help improve patient throughput and staff experience. So let me introduce the team that is going to discuss everything today. So we have Matthew, who is a nurse informatician, Kylie, the risk management director, Sophia, the charge RN, Deidre, the med-surg staff RN, Natasha, the discharge lounge coordinator, Jordan, the case management, and Eve, quality improvement coordinator. Each member will present data supported strategies from their role to implement and sustain improvements hospital-wide. Okay, Matthew, I'll turn the time over to you now.
Thank you, John. Hello, everyone. My name is Matthew, and I'm the nursing informaticist here at the hospital. I would like to start by saying how poor EHR usability contributes to many of the medical errors we see on the floors here at our hospital and leads to staff workarounds with some of these issues. As Cudney Lee et al. Said in 2021, discusses digital workflow misalignments increase the risk for patients as well as inefficiency in how the hospital is ran. To support safe transitions moving forward for our future, I would like to say how I'll be co-designing an EHR template with end users for discharges, transfers, and admissions to make the processes easier for our staff. I will create a real-time dashboard that will track bed availabilities, predict discharges, and pending transfers on our hospital floors. Predictive analytics to estimate discharge likelihood within 24 to 48 hours to keep staff up to date with patients' plan of care. We'll add a med reconciliation alerts and CPOE override flags to prevent medication safety risk during turnover hours. I'll lead EHR module configurations, testing, and integration with feedback from the frontline staff. So make sure you keep an eye out for those surveys I'll be sending out in your emails. I'll be passing it off to Kylie, our risk management director. Kylie, take over.
Hi, everyone, and thank you for including me. As the risk management director, my priority is ensuring that patient transitions are not only efficient, but also safe and compliant, especially during times of high bed demand and rapid turnovers when risk is elevated. Transitions of care are the most error-prone moments, particularly for medication administration and discharge processes. According to Ab El-Kader et al. 2025, embedded risk protocols and real-time auditing are critical to reducing adverse events during these transitions. To support this initiative, I will track key safety metrics, including medication errors, missed barcode scans, and unverified discharges. These indicators help us proactively address gaps before they lead to harm. I'll also collaborate with IT to embed prompts into the EHR for allergy checks, discharge teaching verification, and cognitive status, ensuring essential steps aren't overlooked under pressure. To promote a culture of safety, I'll develop a no-blame reporting pathway so staff can escalate concerns early without fear of reprisal. In addition, I'll review compliance with hallway placement policies and regulatory standards, especially during surge conditions, to make sure overflow care areas like lounges remain safe and legally compliant. In short, my role is to make sure we implement this turnover model with built-in safety checks, regulatory oversight, and open feedback channels. And with that, I'll hand it over to Sophia, our charge nurse.
Thank you, Kylie. So on the floor, I've observed some frequent workflow disruptions during the turnover process, including missed med scans and delayed discharges. I'm seeing how disjointed turnover teams hurt our workflow. And according to Jennings et al. 2013, poor communication during patient movement increases delays and safety risks. I've pulled out some information from Madero et al. 2023 that I would like to implement as charge nurse. Some of those will be audit compliance with barcode scanning, administration, and rounding accuracy. I'd also like to reinforce job aids and protocols for the turnover team, including discharge lounge processes. I will coordinate with pharmacy, IT, and staffing to reduce redundant steps and ensure timely transitions. The rounding audits will be to check compliance and address real-time med scanning issues. Staff coaching on the barcode scanning and discharge workflows should also help improve this issue. Workflow mapping to streamline steps between MedPass discharge teaching and transfer coordination. I'd also like to do some reinforcement of the discharge lounge usage, ensuring that patients who meet criteria are safely moved from inpatient beds to the lounge in collaboration with Natasha. I'd also like an escalation in the protocol enforcement so that repeated workflow disruptions or med scanning errors are reported immediately, and that will reduce downstream errors. I will lead the daily morning huddles with the team leads to identify workflow gaps in real time, and my overall goal is just to reduce bottlenecks by triaging barriers and empowering frontline nurses. So I will pass it over to Deidre, who is our med-surg staff nurse.
You're muted.
All right, everyone hear me now?
Yes, we do.
All right, thanks. All right, thank you, Sophia. Sorry about that. And hi, everyone, and thanks for giving me the opportunity to speak today. As a floor nurse on our med-surg unit, I see firsthand how challenging the turnovers can be, especially during the peak hours. But I'm really excited about the idea of a dedicated admission and discharge team. Having a specialized group focused solely on turnovers could allow bedside nurses like me to remain more engaged with our current patients. That would reduce stress and prevent errors, I think. I've also seen how chaotic it gets when we're trying to admit one patient, discharge another, and then still respond to call lights and all the changes in condition of our patients. So a team that steps in with a structured, tech-supported process could truly streamline care. We know that admissions, discharges, and transfers often interrupt our ongoing patient care, and they can create workflow bottlenecks that affect both staff efficiency and patient safety. So, from a bedside nurse perspective, turnovers often clash with our critical nursing tasks, increasing our workload and our burnout. If we look at Luther et al. From 2019, that team highlights how discharge responsibilities fall heavily on nurses, leading to documentation errors and teaching delays. So I would like to see documentation in real time for discharges and transfer barriers during our daily huddles. I think that as floor nurses, we can track key performance indicators, the KPIs, like maybe discharge before noon rates, scan compliance, and transfer timing. And I think as floor nurses, we can also serve as a feedback loop, mostly reporting repeated issues back to the committee for rapid response. So again, thanks for involving me, and I'll turn it over to our discharge lounge coordinator, Natasha.
Hello, thank you, Deidre. I'm Natasha, the discharge lounge coordinator. I believe if we increase the utilization of the discharge lounge, we'll see an improvement in overcrowding and turnaround times. I also think this will help mitigate medication issues and improve workload efficiency. So based on my own research, I pulled some information from Woods et al. 2020 and Franklin et al. 2020. I believe we need to make strategic adjustments to the discharge lounge. This includes staff education on how to utilize the discharge lounge, because a lot of staff are not properly utilizing the discharge lounge when they can. Activate patient identification, so who is eligible for the discharge lounge, and then timely visual prompts when discharge orders are placed. So the two articles that I mentioned describe successful discharge lounges as structured environments with defined roles and protocols. So as your discharge lounge coordinator, I will implement lounge staffing workflows safety checks, and handoff protocols. I will monitor lounge occupancy and report any delays, and I will coordinate with units for proper identification, timely handoffs, and patient family communication. And with that being said, I am going to pass it over to our case manager, Jordan.
Hey everyone, thanks for the introduction, Tasha. What I really want to discuss is that discharge delays aren't just clinical. They're often tied to non-medical barriers like transportation, follow-up care, or equipment access. Bieler et al. 2019 and Ota et al. 2016 support pre-discharge screening and structured communications to better streamline this process and take some of that workload off of our floor nurses. My responsibilities would be to use EHR workflows to ensure case management checkpoints are completed before the patient discharge, integrate auto prompts for community resources such as home health and outpatient appointments, monitor length of stay and readmission risk dashboards. And what I really want to implement is a discharge risk assessment. This will reduce our readmission rates and hopefully keep us more organized on where this patient is going if it's appropriate and allow for better utilization of the lounge. So I'll coordinate with Tasha to improve our lounge throughput and overall streamline our social services referral. I'd love to hear from Eve about our quality improvement and how we can make this just even better.
All right, appreciate it. Thanks, Jordan, for reminding us how important it is to measure our results. Hi, everybody. I'm your QIR coordinator. So my job is to find simple, practical ways to improve how we do things. One method I would like us to use is the PDSA cycles, which stands for Plan, Do, Study, and Act, which means we'll test a small change, see if it works, then we make it better or expand it. For example, we can try faster discharge steps in one unit and improve how we scan medication during transfers. To measure how well these changes are working, we can we'll create a dashboard that shows how important numbers like how many patients are discharged before noon, how long patients wait after the doctor gives the discharge order, and how many medication errors happen during patient movement. The dashboard will help everyone clearly see what's improving and what still needs to work. According to Garcia and colleagues in an article in 221, using tools like lean methods and focusing on the discharge process can cut discharge times in half and reduce mistakes by 70%. Another article by Hernandez and colleagues in 214 also showed that updating how we use the discharge lounge helped reduce patient wait times and even increase early discharges. These changes that don't really need extra money, just better teamwork and communication. And for the final one with the boss. Take it home, John.
Thank you, Eve. Okay, so thank you everyone who has been involved in this. This team has presented an aligned EBP-driven approach that leverages each person's roles and their strengths. So here is our proposed action plan. For implementation design, Matthew is going to co-design EHR workflows. Natasha will be on the discharge lounges. Jordan will work on discharging risk assessments and checkpoints. Sophia will work on the workflow mapping and rounding audits. Kylie will work on real-time error tracking, and Deidre will work on the KPI collection. For the pilot phase, it will launch August 1st in the MedSurg unit. We're going to be, Sophia and myself will discuss daily morning huddles, and then Eve will do the weekly review and data debrief. As well, Matthew will work on the real-time alerts and communication dashboards. So for evaluation and scale, the data review will be in September, and this will expand protocols hospital-wide if the pilot test is successful. Eve will submit the monthly KPI trends, and then I will secure resources and finalize training investments. In terms of daily workflow, we're going to work on the morning huddle through review discharges and dashboard alerts. We're going to initiate a midday push and focus on discharge before noon. And then for the afternoon debrief, we're going to analyze safety events and assign next day tasks. And to finish this up, according to Cutney Lee et al. 2021 and Sean et al. 2023, investing in EHR usability and streamlined workflows directly improve nurses' efficiency and patient outcomes. And I will champion these changes at the executive level to ensure support. Thank you all so much for contributing and bringing up this information, guys.